Hello and welcome dear students. Today we are going to discuss the regulation and disorders of adrenal glands. The objectives of today's lecture are to have a brief look at the adrenal glands, to understand the regulation of secretion of adrenal cortex, followed by the regulation of secretion of adrenal medulla hormones, and we will also have a look at the disorders of adrenal glands such as Cushing syndrome. To begin with, let us first talk about the adrenal gland. The two adrenal glands, each of which weighs about 4 grams, lie at the superior poles of the two kidneys. As you can see in the figure, each gland is composed of two distinct parts, the adrenal medulla and the adrenal cortex. The adrenal medulla, the central 20% of the gland, is functionally related to the sympathetic nervous system. It secretes the hormones like epinephrine and norepinephrine in response to sympathetic stimulation. In turn, these hormones cause almost the same effects as direct stimulation of the sympathetic nerves in all parts of the body. The adrenal cortex secretes an entirely different group of hormones called corticosteroids. These hormones are all synthesized from the steroid cholesterol and they have similar formulas. However, slight difference in their molecular structures give them several different but very important functions. Two major types of adrenocortical hormones, the mineralocorticoids and glucocorticoids, are secreted by the adrenal cortex. In addition to these, small amounts of sex hormones are secreted, especially androgenic hormones, which exhibit the same effects in the body as the male sex hormone testosterone. They are normally of slight importance, although in certain abnormalities of the adrenal cortices, extreme quantities can be secreted and can result in masculinizing effects. The mineralocorticoids have gained this name because they especially affect the electrolytes, the minerals of the extracellular fluids, sodium and potassium in particular. The glucocorticoids have gained their name because they exhibit important effects that increase blood glucose concentration. They have additional effects on both protein and fat metabolism that are equally as important to body function as their effects on carbohydrate metabolism. More than 30 steroids have been isolated from the adrenal cortex, but two are of exceptional importance to the normal endocrine function of the human body: aldosterone, which is the principal mineralocorticoid, and cortisol, which is the principal glucocorticoid. Let us now discuss in detail the regulation of hormones secreted by the adrenal gland. First, we will discuss the regulation of secretion of aldosterone. Regulation of aldosterone secretion is deeply intertwined with regulation of extracellular fluid electrolyte concentrations, extracellular fluid volumes, blood volumes, arterial pressure, and many special aspects of renal function that it is difficult to discuss control of aldosterone secretion independently of all these other factors. However, it is important to discuss here some of the more important points of aldosterone secretion control. Regulation of aldosterone secretion by the zona glomerulosa cell is almost entirely independent of regulation of cortisol and androgens by the zona fasciculata and zona reticularis. The aldosterone secretion is regulated by 4 important factors, which are increase in potassium ion concentration in the extracellular fluid, decrease in sodium ion concentration in the extracellular fluid, decrease in extracellular fluid volume, and the presence of adrenocorticotropic hormone ACTH. increase in the concentration of potassium ions is the most effective stimulant for aldosterone secretion. It acts directly on the zona glomerulosa and increases the secretion of aldosterone. Decrease in sodium ion concentration and extracellular fluid volume stimulates aldosterone secretion through renin-angiotensin mechanism as shown in the figure. Renin secreted from juxtaglomerular apparatus of kidney acts on angiotensinogen in the plasma and converts it into angiotensin first, which is converted into angiotensin second by converting enzyme secreted by lungs. Angiotensin second acts on the zona glomerulosa to secrete more aldosterone. Aldosterone in turn increases the retention of sodium and water and excretion of potassium ion. This leads to an increase in the sodium ion concentration and the extracellular fluid volume. This increased sodium ion concentration and the extracellular fluid volume inhibit the juxtaglomerular apparatus and stop the release of renin. So, angiotensin second is not formed and release of aldosterone from adrenal cortex is stopped. It should be noted here that adrenocorticotropic hormone mainly stimulates the secretion of glucocorticoids. It has only a mild stimulating effect on aldosterone secretion. Now, as we have discussed the regulation of aldosterone secretion, we will further discuss the regulation of secretion of glucocorticoid hormone. Unlike aldosterone secretion by the zona glomerulosa, which is controlled mainly by potassium and angiotensin second acting directly on the adrenal cortical cells, secretion of cortisol is controlled almost entirely by ACTH or adrenocorticotropin hormone that is secreted by the anterior pituitary gland. This hormone is also called corticotropin or adrenocorticotropin, which enhances the production of adrenal androgens. ACTH secretion is further controlled by corticotropin releasing hormone from the hypothalamus. The principal effect of ACTH on the adrenocortical cells is to activate adenylyl cyclase in the cell membrane. This then induces the formation of cyclic AMP in the cell cytoplasm, reaching its maximal effect in about 3 minutes. The cyclic AMP in turn activates the intracellular enzymes that cause formation of the adrenocortical hormones. This is another example of cyclic AMP or cyclic adenosine monophosphate as a second messenger signal system. Long-term stimulation of the adrenal cortex by ACTH not only increases secretory activity but also causes hypertrophy and proliferation of the adrenocortical cells, especially in the zona fasciculata and zona reticularis, where cortisol and androgens are secreted. Cortisol has direct negative feedback effects on the hypothalamus to decrease the formation of CRF or cortisol releasing factor and the anterior pituitary gland to decrease the formation of ACTH. It should be noted that both of these feedbacks help regulate the plasma concentration of cortisol. Now that we have learned the regulation of glucocorticoids, let's summarize the cortical control system. The key to this control is the excitation of the hypothalamus by different types of stress. Stress stimuli activate the entire system to cause rapid release of cortisol, and the cortisol in turn initiates a series of metabolic effects directed towards relieving the damaging nature of the stressful state. There is also direct feedback of the cortisol to both the hypothalamus and the anterior pituitary gland to decrease the concentration of cortisol in the plasma at times when the body is not experiencing stress. However, the stress stimuli are the most potent ones. They can always break through this direct inhibitory feedback of cortisol, causing either periodic exacerbations of cortisol secretion at multiple times during the day or prolonged cortisol secretion in times of chronic stress. Now let us have a look at the regulation of secretion of hormones from the adrenal medulla. Adrenaline and noradrenaline are secreted from adrenal medulla in small quantities even during rest. During stress conditions due to sympathoadrenal discharge, a large quantity of catecholamines is secreted. These hormones prepare the body for fight or flight reactions. Catecholamine secretion increases during exposure to cold and hypoglycemia. The sympathetic nervous system, including its adrenal medullary component, is activated by any actual or threatened change in the internal or external environment. It responds to physical changes, emotional inputs, and anticipation of increased physical activity. Input reaches the adrenal medulla through its sympathetic innervation. Signals arising in the hypothalamus and other integrating centers activate both the neural and hormonal components of the sympathetic nervous system, but not necessarily in an all or none fashion. Activation may be general or selectively limited to discrete targets. Norepinephrine or epinephrine secreting cells can be preferentially and independently stimulated as shown in figure. In response to hypoglycemia detected by glucose monitoring cells in the central nervous system, the concentration of norepinephrine in blood may increase threefold, whereas that of epinephrine, which tends to be a more effective hyperglycemic agent, may increase 50-fold. As we have learned about the regulation of hormone secretions, we will have a look at the disorders of adrenal glands. The disorders of adrenal glands can be divided into two types: disorders of adrenal cortex and disorders of adrenal medulla. Let us begin with the disorders of adrenal cortex, in which we will first discuss the hyperactivity of adrenal cortex and the conditions it leads to. Then we will be discussing the hypoactivity and its effects. Now let us first discuss hyperactivity of adrenal cortex. Hypersecretion of adrenocortical hormones leads to the following conditions: Cushing's syndrome, hyperaldosteronism, adrenogenital syndrome. Now let's have a look at the Cushing's syndrome. Hypersecretion of cortisol by the adrenal cortex produces Cushing's syndrome. Causes include a tumor of the adrenal gland that secretes cortisol, or a tumor elsewhere that secretes adrenocorticotropic hormone, or ACTH, which in turn stimulates excessive secretion of cortisol. The condition is characterized by breakdown of muscle proteins and redistribution of body fat, resulting in spindly arms and legs accompanied by rounded moon-faced buffalo hump on the back and pendulous or hanging abdomen. Facial skin in these patients is flushed and the skin covering the abdomen develops stretch marks. The person also breathes easily and wound healing is poor. The elevated level of cortisol causes hyperglycemia, osteoporosis, weakness, hypertension, increased susceptibility to infection, decreased resistance to stress, and mood swings. People who need long-term glucocorticoid therapy, for instance, to prevent rejection of a transplanted organ. Now let's have a look at hyperaldosteronism. Increased secretion of aldosterone is called hyperaldosteronism. Depending upon the causes, hyperaldosteronism is classified into two types: primary hyperaldosteronism and secondary hyperaldosteronism. We will first understand what is primary hyperaldosteronism. Primary hyperaldosteronism is also known as Conn's syndrome. It develops due to tumor in zona glomerulosa of adrenal cortex. The most important effects are hypokalemia, mild metabolic alkalosis, a slight increase in extracellular fluid volume and blood volume, a modest increase in plasma sodium concentration, and hypertension. Especially interesting in persons with primary aldosteronism are occasional periods of muscle paralysis caused by the hypokalemia. The paralysis is caused by a depressant effect of low extracellular potassium concentration on action potential transmission by the nerve fibers. One of the diagnostic criteria of primary aldosteronism is a decreased plasma renin concentration. This decrease results from feedback suppression of renin secretion caused by the excess aldosterone or by the excess extracellular fluid volume and arterial pressure resulting from the aldosteronism. Treatment of primary aldosteronism may include surgical removal of the tumor or of most of the adrenal tissue when hyperplasia is the cause. Now, let us have a look at secondary hyperaldosteronism. Secondary hyperaldosteronism occurs due to extra-adrenal causes such as congestive cardiac failure, nephrosis, toxemia of pregnancy, cirrhosis of liver. Now, what are its signs and symptoms? Increase in extracellular fluid volume and blood volume, hypertension due to increase in extracellular fluid volume and blood volume, severe depletion of potassium which causes renal damage. The kidneys fail to produce concentrated urine. It leads to polyuria and polydipsia. Muscular weakness due to potassium depletion. Metabolic alkalosis due to secretion of large amount of hydrogen ions into the renal tubules, and metabolic alkalosis reduces blood calcium levels causing tetany. Coming to the adrenogenital syndrome. Under normal conditions, adrenal cortex secretes small quantities of androgens which do not have any significant effect on sex organs. However, secretion of abnormal quantities of adrenal androgens develops adrenogenital syndrome. This is caused due to the tumor of zona reticularis in adrenal cortex. Adrenogenital syndrome is characterized by the tendency for the development of secondary sexual character of opposite gender. Now, we will discuss the disease caused by the hypoactivity of the adrenal cortex. Hyposecretion or hypoactivity of adrenocortical hormones leads to the following conditions: Addison's disease or chronic adrenal insufficiency, congenital adrenal hyperplasia. We will be discussing each separately. First, we will focus on Addison's disease. The hyposecretion of glucocorticoids and aldosterone causes Addison's disease. The majority of cases are autoimmune disorders in which antibodies cause adrenal cortex destruction or block binding of ACTH or adrenocorticotropic hormone to its receptors. Pathogens such as the bacterium that cause tuberculosis also may trigger adrenal cortex destruction. Symptoms which typically do not appear until 90% of the adrenal cortex has been destroyed include mental lethargy, anorexia, nausea and vomiting, weight loss, hypoglycemia and muscular weakness. Loss of aldosterone leads to elevated potassium and decreased sodium in the blood, low blood pressure, dehydration, decreased cardiac output and even cardiac arrest. The skin may have a bronzed appearance that often is mistaken for suntan. Now, let us have a look at congenital adrenal hyperplasia. Congenital adrenal hyperplasia is a congenital disorder that is characterized by an increase in size of adrenal cortex. Size increases due to abnormal increase in the number of steroid secreting cortical cells. Even though the size of the gland increases, cortisol secretion decreases. It is because of the congenital deficiency of the enzymes necessary for the synthesis of cortisol. In females, adrenal hyperplasia produces masculinization, which is otherwise called virilism. In some cases of genetic disorders, the female child is born with external genitalia of male type. This condition is called pseudohermaphroditism. Now, we will discuss the disorders of adrenal medulla, which includes pheochromocytomas. Usually benign tumors of the chromatin cells of the adrenal medulla are called pheochromocytomas, which cause hypersecretion of epinephrine and norepinephrine. The result of this hypersecretion is a prolonged version of the flight or fight response, that is rapid heart rate, high blood pressure, high levels of glucose in blood and urine. an elevated basal metabolic rate, flushed face, nervousness, sweating, and decreased gastrointestinal motility. Its treatment involves surgical removal of the tumor. Dear students, it was all about today's lecture. Hope you have understood well. Thank you and goodbye.